Our presenter is Allison Tagliaferro, and she is finishing up her DNP right now. And this is some work that we have done together. So my name is Dr. Domenico, and I am president of the Florida chapter of INSA and president-elect for INSA USA. And Allison has been working quite closely with us to put all of this together for everyone. So I'll hand it over to her.
Sounds good. Good afternoon, everyone, and thank you so much for the wonderful introduction. I'm very happy to be here to provide some information on the guidelines and tools for navigating the opioid epidemic. And I'm going to jump into the content of the presentation in just a moment. But before I do, I wanted to just go over the agenda and learning objectives for the CE activity. So here I've listed the learning objectives. They are also found on your webinar registration for your review. And then today, I'll first be providing a brief overview on pain and opioids. Then we'll be discussing the trends and impact of the opioid epidemic. After, we're going to get into some of the best practices for safe opioid prescribing, and then discuss opioid use disorder. And Florida-specific information will follow at the end of the presentation. And throughout the presentation, you're going to see a badge icon over here, and it indicates this is a resource that's included on the INSA toolkit. And that should have been provided to you in the chat box. And before we get going, as a last minute reminder, if you haven't done so already, please complete the pre-survey using the link that's provided in your registration confirmation. I've also included it here in the chat. And at the end of the presentation, a link to the post survey will be distributed in the chat as well. So let's get started. So first, we'll have to answer the question, what's an opioid? According to the CDC definition in the 2022 guidelines, opioids are any natural, synthetic, or semi-synthetic chemicals that interact with opioid receptors on nerve cells throughout the brain and body and reduce the intensity of pain signals and feelings of pain. And they have developed some new definitions in their guideline, the 2022 guideline. That includes some recommendations based on the different categories of pain. So I've included them here. Acute pain is pain lasting less than 1 month. The subacute pain lasts anywhere from 1 to 3 months, and chronic pain lasts greater than 3 months. Our next circle here shows some images of the opium poppy. Opium is harvested by scoring the plant and harvesting the dried white substance on the exterior, and then processing it into a resin. And this process has been performed for thousands of years, with evidence of it dating back to 3400 BC. And opium is still harvested medicinally today. Much of that production is performed in India, Turkey, and Australia, and it provides over 2,000 tons annually to make medicinal product. This next circle is a very simplified visual of how opioids work. They work by binding to nerve receptors, which then modulate pain signals. And the activation of the mu receptor is how opioids exert most of their analgesic properties. And it's most implicated in opioid misuse and opioid use disorder treatment. When opioids bind to a receptor, there's an increase in dopamine release. And this increase in dopamine release causes the feeling of euphoria. And our next circle goes over a statistic. In 2020, there were 143 million opioid prescriptions that were filled in the United States. This number is actually decreasing, but prescription opium use is still extremely prevalent and plays a large role in healthcare. So opioids are controlled substances. They fall into every category on the DEA schedule, depending on their associated risks. And here I've included a pared down version of the DEA schedule. And you can see at the top, Schedule I substances have no currently accepted medical use and a high potential for misuse. And an example that I've listed here is heroin. Other examples include LSD, ecstasy, peyote. And on the bottom of the list is a Schedule V substances, which have a lower potential for misuse and consists mostly of antipsychotic preparations with small quantities of certain opioids. And I have linked the entire DEA schedule to the toolkit. This graphic just provides a visual of potency among commonly used opioids, which segues into our last circle on morphine milligram equivalents. And the morphine milligram equivalent, or MME, is a unit of measurement that's used to specify total daily dose of opioids with respect to morphine. And each opioid has its own unique conversion factor to allow for this calculation. And this is important because certain levels of daily MME are associated with increased risks. So we're going to be going over this later in the presentation. All right, so I have set up some little quizzes throughout the presentation. It's time to test your knowledge. So the first question I have here, true or false, opium was discovered first in the 1990s. So I'll give you a few minutes just to kind of mentally respond, but hopefully you got this right. Opium use has been documented as far back as 3400 BC. Fill in the blanks. Scheduled blank drugs have no accepted medical use and a high potential for misuse. An example of an opioid in this schedule class is blank. So we went over this on the last slide. Currently, Schedule 1 drugs have no accepted medical use and high potential for misuse. And an example that I provided was heroin. And which neurotransmitter is released when opioids bind to a receptor and is responsible for a feeling of euphoria? And the answer to that one is dopamine. Okay. So this slide depicts an abbreviated timeline of the opioid epidemic. In the 1990s, increased prescribing of prescription opioids led to an increase in overdose deaths, and this is largely fueled by misinformation about the addictive properties of opioid medications. Then in 2010, we saw an increase of opioid deaths involving heroin, followed by an increase in opioid deaths from synthetic opioid use in 2013. And then in 2017, the HHS declared the opioid crisis as a public health emergency. And then in 2020, COVID-19 impacted the nation. And during this time, the US actually saw an increase of 31% in opioid overdose deaths. And this was largely due to the mental and physical impacts of the pandemic combined with missed opportunities for intervention. So this graphic from the Department of Health and Human Services reveals statistics on just how devastating the opioid epidemic has been for our nation. This is based on data actually from the 2019 survey. And since then, many of these numbers have worsened. Here, I'd like to draw your attention to this graph, which is from the AMA 2021 Overdose Epidemic Report. Thankfully, trends show a slight decrease in overdose deaths from heroin and prescription opioids. However, there's an overwhelming increase in overdose deaths from synthetic opioids like fentanyl. And additionally, there have been increases in overdose deaths from psychostimulants, as well as an overall 15% increase in overdose deaths from all opioids from 2020 to 2021. I also just want to take a moment to talk about the CDC SUDRS, which stands for State Unintentional Drug Overdose Reporting System, and DOSE, the Drug Overdose Surveillance and Epidemiology System dashboards. They're great resources for reviewing trends in non-fatal and fatal overdose statistics. I know that not all states are participating. However, if you're interested in the epidemiological data, these tools are wonderful resources to check out in addition to the data provided by the National Survey on Drug Use and Health. And I've linked those to the toolkit. So as discussed in the previous slide, fentanyl is currently driving addiction and overdose in the US right now. And this substance is 50 times more potent than heroin, and therefore extremely small amounts can be lethal. It's currently being incorporated into other substances as well as counterfeit pills, and this is contributing to unintentional overdose. And as a result, in 2021, the DEA launched their One Pill Can Kill campaign to bring further awareness to this issue. And I've linked the fact sheets for this campaign in the INSA toolkit, and one is specifically for parents and caregivers. This image on the top right just shows how similar kind of counterfeit medications can appear. And on the bottom, I have a shocking statistic that was actually just recently updated. According to the DEA lab testing, 6 out of every 10 pills containing fentanyl contains a lethal dose. So it used to be 4, and they just released this data from 2022. It's now 6. So we have another test your knowledge. The COVID-19 pandemic had devastating effects on the opioid crisis. From 2019 to 2020, the national rate of drug overdose deaths in the US increased by, so we have 11%, 75%, 4%, or D, 31%. And the answer here, hopefully you got this right. I talked about this in the timeline. It is D, 31%. True or false, the CDC described 3 waves of the opioid crisis, the first starting with increased heroin use in the 1980s. And this is false. The first wave started in the 1990s, and that was marked by increased overdose deaths associated with prescription opioid use. And what is the leading cause of overdose deaths in the US today? It's due to what synthetic drug? And the answer is fentanyl. Okay. So now we're going to get into some of the best practices in opioid prescribing. It's important to note that much of the information that will be covered in this section is based on the 2022 CDC clinical practice guidelines for prescribing opioids. This guideline doesn't pertain to the entire patient population. It specifically includes pain management related to sickle cell disease, oncology related pain, palliative care, and end-of-life care. And it's also states that it's meant to be applied in non-acute settings, such as outpatient offices, clinics, or urgent cares. And I have linked this guideline to the toolkit as well. So this is just some treatment considerations. They're general principles for pain management, which are broad and can probably be extended to many treatment areas in healthcare. The first being the importance of individualized care. Risks and benefits for each patient are unique and should be weighed carefully in treatment decisions. And guidelines are really not meant to be a stringent set of governing rules, but are instead meant to support patient-centered care. And that's a point that the CDC makes in this 2022 guideline. Of course, the patient should be included in decisions made about their care. Shared decision-making has many established benefits. Listing the expertise of specialists in a multidisciplinary effort can help expand treatment resources and ensure patient safety. A lot of patients, more complex patients, may require a referral to a specialist. We want to make sure we're making these referrals, especially if the care exceeds our scope of training or comfort level. And then the CDC emphasizes using a multimodal approach to address pain. And that's another overarching guiding principle for acute pain, and also for acute, subacute, and chronic pain. Non-opioid therapies should be maximized as appropriate for the condition. And I'm going to talk about that a little bit on the next slide. So this slide just reviews some of the non-opioid treatments for pain. For acute, subacute, and chronic pain, maximization of those non-opioid modalities should be applied. The CDC addresses many conditions where they recommend some non-opioid therapies, including lower back pain, musculoskeletal injuries, dental pain, kidney stone pain, migraines, but also addresses some recommendations for chronic conditions such as diabetic neuropathy, osteoarthritis, neuropathic pain in general, and fibromyalgia. So we do want to be able to offer these non-opioid therapies. And it might, another point that was brought up in this guideline is to become familiar with some of these recommended low-cost therapies in your surrounding area, because a lot of the non-pharmacological therapies may not be covered by third-party payers. So it's good to be familiar with like a great walking path or a certain type of yoga or exercise class to be able to offer those types of things to your patients as well. And then I've included on the guideline some on the toolkit, some additional guidelines that have common pain conditions. So before prescribing an opioid, of course, we want to perform an assessment that includes the HPI review systems, functional and physical pain focused exams. You want to look at available diagnostics, perform a thorough medication reconciliation. That's very important. So that way you can prevent any drug-to-drug interactions and perform mental health screenings as well as opioid risk screenings. Establishing and confirming a diagnosis is essential so that condition-specific treatment can be implemented. And the CDC actually uses the example of diabetic neuropathy, and by addressing the underlying cause, which in this case would be achieving better glucose control, it prevents the worsening of the painful condition. So we do want to establish and confirm the diagnosis. And prior to initiating opioid treatment, it's important to establish goals for pain and function, because this is what you're going to be looking at when you monitor for clinically significant improvements. Of course, discussing risks and benefits. It's very important to consider each individual circumstance and overall clinical picture when weighing the risks and benefits. And the CDC recommends being upfront and realistic when discussing risks and benefits for use in pain. And then when initiating opioids for subacute or chronic pain, it's recommended that a plan be in place for discontinuation, including reasons for possible discontinuation. You want to be prepared for that ahead of time. Addressing potential side effects is very important. The anticholinergic effects from opioids can be more pronounced, especially in elderly populations, and anything you can do to mitigate those side effects, such as prescribing a laxative along with the opioid, it can be beneficial in that population. And then prior to initiating opioids for subacute or chronic pain, you want to consider urine toxicology, and this should be done prior to initiation and then at least once per year to identify any substances and also a possible diversion. And then consider establishing a formal agreement and ensuring some compliance with each evaluation. This is actually a requirement in my state to establish a formal patient agreement, and you want to ensure it addresses certain components of opioid therapy that your state may require. So I have one link to the toolkit here. It's from NIDA, so you can check that out. And of course, as we talked about, offer non-opioid therapies. So the CDC does indicate that opioids do play a role in some acute pain conditions related to severe traumatic injuries, crush injuries, burns, invasive surgeries. So when you do have to initiate an opioid, you want to prescribe immediate release opioids first at the lowest possible dose. Prescribing immediately released fast-acting medication with a shorter duration of analgesic effect is preferred. And examples of this include that they provide are hydrocodone, morphine, or oxycodone at the lowest available dose. And for opioid-naive patients, it recommends doses of 5 to 10 MMEs or daily dosing of 20 to 30 MMEs, which can be appropriate. Of course, we only want to prescribe only the quantity needed and none extra just in case. And avoid increasing to a dose with diminishing benefit relative to the risk. So there's a condition called opioid-induced hyperalgesia, which is actually a paradoxical response. It happens when the pain thresholds decreased and often with long-term opioid therapy use, and the pain actually worsens despite increasing doses of opioids. So that's something to keep in mind. And then for acute pain, only want to prescribe only as needed and avoid scheduled doses. So we've spoken about the importance of weighing individual risks and benefits and some of the side effects of opioid use, but I wanted to highlight some of the physiological effects associated with opioids. As you can see, I've listed some on the left-hand side of the screen here, some short-term effects and long-term effects. And this graphic here on the right is presented in the American Journal of Cardiology. It shows the physiological effects that natural and synthetic opioids have on the cardiovascular system. And you'll notice here that certain synthetic opioids can cause QT prolongation over time. And this delay in ventricular repolarization can then lead to arrhythmias, which can then lead to further cardiac complications. So obtaining a baseline on your patients, especially for a baseline EKG, just to make sure that they're safe and that they don't have any existing QT prolongations, important to keep in mind, especially when prescribing certain synthetic opioids such as methadone. And then this slide goes over addressing some known risks. The CDC explains to use caution with concurrent use of benzodiazepines. Of course, concurrent use carries risks of respiratory depression, which can lead to overdose and death, especially when combined with any other CNS suppressants like alcohol. Certain conditions, though, they say that may warrant concurrent prescribing, and stopping the benzodiazepine can cause destabilizing effects. However, we definitely want to make sure we are educating, providing thorough patient education on this, checking the PDMP, and of course, weigh risks and benefits. If the risks outweigh benefits, consider tapering the benzodiazepine. We want to screen for mental health conditions using validated tools, since mental health can play a role in exacerbation of pain and limiting improvements in pain. Identifying conditions and offering treatment is so extremely important. For patients with history of substance misuse or overdose, you want to ensure that you're performing screening, such as screening for opioid use disorder, and in addition to having conversations and providing overdose education and discussing the risks for overdose. So interdisciplinary communication is also important here if the patient is under the care of a specialist who is managing opioid use disorder, or even establishing a plan with the patient ahead of time to speak with a trusted family member, if that's allowed, so you want to make sure that you do that ahead of time. And then for high dosing, which is greater than 50 MMAs daily, you do want to consider the risks versus benefits. Heavily, the CDC recommends a pause here because many patients do, or that physicians pause before increasing dosing above this point, because many patients don't experience benefit in pain or function from increasing doses beyond 50 MMAs daily, but are exposed to the progressive increase in risks. So therefore, this is why they recommend that they carefully reassess and approach doses above 50 MMAs daily with caution. Because above 50 MMAs daily also increases risk for overdose, and we do want to co-prescribe naloxone with dosing above that point. For mild sleep disorder breathing, the CDC recommends that close monitoring, careful dosing adjustment be implemented, but for those with moderate to severe sleep disorder breathing, they recommend avoiding prescribing opioids because this carries severe life-threatening respiratory depression threats. So this is something that you do want to discuss with your patient, and they recommend avoiding. And then for patients with renal and hepatic insufficiency, consider dosing adjustments and increased monitoring. And for those greater than 65, it's important to perform fall risk assessments, as we discussed, going over side effects such as constipation, performing a medication reconciliation. I know polypharmacy is very common in this patient population, so you do want to provide that thorough medication reconciliation to screen for any potential drug-to-drug interactions. So this slide goes over the prescription drug monitoring programs, and these are state implemented tools to help track prescribing and dispensing of controlled substances. They're meant to decrease diversion and identify misuse. This should be documented in the record whenever a query is run. Each prescriber, dispenser, or their designee should consult the PDMP each time a controlled substance is prescribed or dispensed to a patient 16 years or older. And it's important to remember to apply the use of the PDMP in the same manner for all patients to avoid any bias And ideally, this should be checked every time. Should the PDMP query result in any unexpected prescription refills, it's important to have a conversation with the patient. Speak with the patient, don't dismiss patients entirely based on results, and it's an opportunity to have a conversation regarding the planned treatment, and if warranted, utilizing any screening tools available, which we'll be talking about further in the presentation. And I've linked, the eForce is Florida's PDMP system. It was implemented in 2009. And I have linked the training guide and integration guide to the toolkit. So now it's time for another test your knowledge. True or false? You do not have to run a PDMP query when prescribing Schedule 3 through 5 drugs. Answer false. So you just talked about that. It ideally should be run with every time you're prescribing a controlled substance. So fill in the blank. Daily doses of blank MME or greater places a patient at high risk for overdose. And the answer here is 50 MMEs or greater. So now I wanted to talk about a little bit about tapering. I have reasons for tapering listed here on the left. It's important to note that tapers should be individualized. Slow tapers are generally better tolerated versus fast tapers, which is a 10% dosing reduction per month. Pauses in tapering may be necessary, but once the lowest dose is achieved, then you can space out the medication. And then once the lowest dose is taken less than once per day, then the medication can be stopped. And it's important to note that this is a very distressing time for the patient. So, and it's accompanied by uncomfortable physiological symptoms for many patients. And we want to ensure that they have appropriate psychosocial support in place prior to initiating a taper. Studies have shown success with weekly follow-up during this time, but at least a monthly follow-up should be provided. And on the INSA toolkit, I've included 2 tapering resources, one from the HHS and one from the 2016 CDC guideline. It's a pocket guide to tapering. Moving on to monitoring. After dosing adjustments or initiation of a medication, patients should be evaluated within 1 to 4 weeks according to the CDC. But for acute pain, the CDC specifies patients should be evaluated at least every 2 weeks for acute pain. Otherwise, patients who are taking opioids for subacute or chronic pain should be evaluated at least every 3 months. During this visit, we want to ensure that we're evaluating the established goals of opioid therapy by assessing pain and function. And here I've included an image of the pain average enjoyment of life and general activity scale, or PEG scale for short. And by completing this scale, we can see then meaningful improvements in pain levels. And I have linked that to the toolkit as well. So this next slide goes over calculating morphine milligram equivalents. Calculating the daily MME helps identify patients who benefit from additional measures to reduce overdose risk. It should also be documented in the patient's record. And each opioid has its own unique conversion factor. It's displayed on the table in milligrams per day, with the exception of fentanyl, which is displayed in micrograms per hour. I know that Florida, our PDMP calculates the daily MME, but I know that I thought I would show you how to hand calculate. The way MME is calculated is by taking the dose of milligrams, multiplying that number by the number of doses per day, and then multiplying that number by the conversion factor. So, and then if a patient's on multiple opioids, then at this point, the values can be added together. And this should not be used to calculate equivalent dosing of note. And this is the table I provided here is from the 2022 CDC guideline. They've specified that this is now going to be the sole resource for the CDC. I know in the past I've seen other versions of this table where there's like dose specific conversion factors for methadone, but this is the one that is most current on their guideline. And I gave a little example here. So calculating a daily MME for a patient who's prescribed 10 milligrams of oxycodone twice daily. So I took 10 milligrams, multiplied it by 2 because it's 2 doses daily, by the conversion factor, which is 1.5 for oxycodone, and you get the answer of 30 MMEs daily. So this is one of the greatest harm reduction techniques currently is co-prescribing naloxone. I have a statistic here that for every 70 high dose opioid prescriptions, there's only one naloxone prescription dispensed. Naloxone actually displaces opioids from receptor sites in the brain and reverses respiratory depression that leads to cardiac arrest and death. So it's important to consider co-prescribing naloxone. States with naloxone access laws have 14% lower incidence of opioid overdose deaths compared to states without any naloxone access laws. I have linked several resources here. The first are naloxone comparison charts. I don't know if in all areas of the United States there is equivalent access to Narcan, which is the intranasal version. There is a table with different types of naloxone and also administration instructions. And then I have attached the Narcan instructions as well to the toolkit. So addressing health disparities in pain management, we want to become aware of our unconscious and conscious bias that exists in health systems and work to eliminate it. We know that bias exists in management of pain as it relates to race and socioeconomic status. These biases result in less frequent pain assessment, inappropriate medication selection, undertreated pain, less offers to referrals to appropriate resources. So we want to make sure that we are aware of that and that we are using culturally and linguistically appropriate communication and also making accessible communication available for all patients, especially those with disability. Additionally, we want to make sure that we do everything we can to understand, talk to our patients about any barriers they have to care and address them. And then I've included this table on the bottom, which is just discussing potential evidence-based solutions to combating opioid use disorder in specific at-risk populations here. So I've listed some of the warning signs of overdose here. And as providers, we should be able to recognize the signs of overdose and educate our patients and family members so that they can be better prepared to navigate this emergency should they be faced with it. This graphic's actually from the Harm Reduction Coalition. It does accurately depict the steps for responding to an opioid overdose. I also linked to the toolkit, a helpful resource, which is published by SAMHSA in June of 2018. It's the Opioid Overdose Prevention Toolkit, and it's for first responders, prescribers, patients, and family members. And it goes over safety information for family members as well. So that is also linked to the toolkit. This slide reviews information on urine drug testing. Urine drug testing can identify any concomitant use of other substances and also identify potential diversion. And for pain that's suggested, as I mentioned, the benefits be considered prior to initiating therapy and at least annually. I know for opioid use disorder, this is used prior to initiating MAT therapy and then also randomly. But it's important to be familiar with how to interpret urine toxicology, as the results are there can be limitations and it could get a little tricky. But for example, specific opioid testing resulting screening may be positive for metabolites of a medication that the patient is taking. And I've seen this metabolite chart several times, but I have it here in the AFP guideline. They have step-by-step of how to order and interpret urine drug tests. So I thought that was a helpful resource. I'd link to the toolkit as well as the other two I've listed up top. One's from SAMHSA and the other one's from ASAM. So this is extremely important. The proper storage of medications is imperative to discuss with our patients. Medication should be locked out of a child's or pet's reach and in the original container, and we want to advise not to share any medications. And the best way to dispose of medications are at permanent disposal sites or at take-back events. These are run through the DEA, and I've linked to the toolkit, the website where you can just input your zip code and it gives you the locations of these disposal sites. So I have them there, and then the take-back events, it's this, they are usually run twice a year, they occur. And the same thing applies. You just go to the DA website that I've linked to the toolkit, and you just put in your zip code and it takes you to the nearest, it tells you where the nearest site is. And then additionally, most opioids are on the flush list for the DEA, deeming them okay to flush. If you're not near one of these disposal sites, of course, their disposal sites are preferred, since we do want to make sure we're environmentally conscious. But ongoing examination of the environmental impacts show preliminary results as negligible, but I'm sure that there'll be more studies on that in the future. So another time to test your knowledge. Oops, I showed the answer too quickly. So true or false, opioids are recommended as first-line treatment for subacute and chronic pain. The answer here is false. Non-opioid therapies are preferred for subacute and chronic pain, and clinicians should maximize the use of non-pharmacological and non-opioid pharmacology therapies. And how often should risks and benefits be reevaluated following initiation of opioids for acute pain? And the answer here is C. According to the CDC guideline, patients should be reevaluated at least every 2 weeks if they consider to receive opioids for acute pain. So now we're going to go over a little bit about opioid use disorder. Opioid use disorder affects over 2 million people in the United States. We spoke earlier about the impact of the opioid epidemic and how this is a growing issue. The diagnosis for opioid use disorder is based on the DSM criteria. The most recent version is DSM-5, and I've included the criteria on the right here. I've also linked the criteria. The CDC has an electronic version of this criteria that you can use, and I've linked that to the toolkit as well. And as you can see, there's different levels of severity depending on how many boxes are checked off on the criteria. And patients who are suspected to have opioid use disorder should undergo an assessment of other possible mental health conditions. The reason being is because their coexistence is so commonly present and with opioid use disorder, and the proper support needs to be in place. When assessing for opioid use disorder, you should include a detailed history of past and present substance use and substance use disorders. And I've also included a lot of what drawn on was from the, in the next few slides, is from the 2020 ASAM National Practice Guideline for the treatment of opioid use disorder. So I linked that as well to the toolkit. This slide just has some terms commonly used with opioid use disorder. These are from the 2020 ASAM guideline. I just thought it was important to note that these are not synonymous terms, and we have to be able to recognize the difference between them. So I have them here. This slide presents SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. It's a specific approach to early intervention. It can be used across a wide variety of settings. In the toolkit, I've included ASAM as a resource on the implementation of SBIRT. So I'm just going to break it down. Unfortunately, there are barriers to screening which exist, and these can include time constraints, lack of provider confidence, and stigma. But screening for this region should be a universal approach. And the screening tool used should address the identified concerning behaviors. So there is linked to the toolkit as well. I've included the NIDA chart, which gives you all the screening tools that are available. It goes over the different population that they're intended for and the administration timeframes for those, like how each one is administered. And then the brief intervention. The brief intervention can be performed in a single visit or across multiple visits. It typically lasts anywhere from 5 minutes to an hour. The goal is to incite change, educate the patient, motivate them to reduce the behavior. This intervention calls upon the use of motivational interviewing, which employs open-ended questions, affirmations, reflections, and summary. This technique can be applied to many different other health conditions where behavior change might be preferred or beneficial for the patient. And if you're not familiar with motivational interviewing, I know there are many different resources out there. And I saw that ASEM is actually having a motivational interviewing webinar at the end of this week. So if you're not familiar, you can check that out. The goals of referral to treatment are to identify the appropriate treatment program and facilitate engagement of the patient with the treatment. It involves a collaborative approach to decide the appropriate treatment option for the patient, taking into consideration their individual circumstance and preferences. This can be a complex process and requires care coordination across multiple providers and settings. So we do want to try our best to ensure the continuity of care so we can facilitate the referral, often making the appointment as needed, verifying insurance, and using this closed loop communication to provide an effective handoff. And then we also want to follow up to ensure that necessary services are received and evaluate to see if this plan did work. And I have included here on the toolkit as well the SAMHSA National Database of Treatment Centers. So now I want to talk a little bit about withdrawal. Withdrawal is caused by the rapid cessation or slowing of use of a substance. And it's also known as spontaneous withdrawal. And of course, we know that the physiological effects of withdrawal can be severe. It's important to recognize signs of withdrawal to prevent these harmful physical effects. And the way we grade withdrawal is using the clinical opioid withdrawal scale, the COW scale, which I have also linked to the toolkit. And I wanted to talk a little bit about precipitated withdrawal, which is just a little different. And precipitated withdrawal refers to condition that occurs when an opioid agonist is displaced from the opioid receptors by an antagonist or even a partial agonist in an opioid dependent individual. And these symptoms can be the same as spontaneous withdrawal, but at times even more severe. And the time frame in which these symptoms occur can be different depending on what type of antagonist or partial agonist is used. So I have some information from the ASAM 2020 guidelines here on spontaneous withdrawal treatment. The important thing here is to remember that detoxification used alone is not a recommended treatment method for opioid use disorder. So here are the medications that are used to treat opioid use disorder. The first medication listed here is buprenorphine. It's a partial agonist. There are many different formulations, including an naloxone combination product, also known as Suboxone. It's widely used due to high binding affinity, which means just a very strong attraction to the receptor site and a slow dissociation. And it can be used during pregnancy and while breastfeeding. as long as you're co-managing with an obstetric physician who has experience in doing so. And there's no recommended length of treatment. It can be used indefinitely due to the chronic nature of opioid use disorder. It also is recommended for long-term use, at least greater than a year. And then it should be initiated when the patient has objective signs of withdrawal. We're going to go over that in a little on our next slide. The second medication listed here is naltrexone. It's a complete opioid antagonist. It is not an opioid. It's available in oral dosing or extended release IM injection. The extended release IM injection given every 28 days seems to be the preferred option. There's better adherence to it. And in order to receive the injection, patients must avoid any type of opioid 7 to 14 days prior. And a naloxone challenge test should be administered prior to the first dose, as long as it's not a pregnant patient. And you do want to be mindful of any patients with hepatic insufficiency, as this medication can cause hepatotoxic effects. And then the last medication I've listed here is methadone. It is an older medication. It's a long-acting full opioid agonist. It comes in liquid, powder, or diskette forms, and by law, only a SAMHSA certified opioid treatment program can dispense methadone for the use of opioid use disorder. But it's still important to know about because your patient may need care coordination or referral to the OTP. Oh, I want to go back to one point here. The comprehensive, something that is noted in the ASAM guideline is that a comprehensive clinical assessment is essential, but it shouldn't delay the initiation of MAT therapy. And I've also included another great resource here, which is the SAMHSA tip 63. It's extensive. It has also formal patient agreements to use prior to initiation of medications for opioid use disorder. So I believe that as well to the toolkit. And then I have some information before initiating what to do before initiating MAT therapy. It includes a review of systems, obtaining a history, performing a physical exam, screening for mental health conditions and suicide risks that we discussed is very important. Want to confirm the diagnosis and develop a treatment plan and perform a medication reconciliation. A lot of this does overlap with prescribing opioids for pain. And what I've listed here is the pocket guide to the 2020 ASAM National Practice Guideline. It does have many flow sheets for a good visual for what to do when initiating MAT therapy. And then I've included some of the lab testing that they recommended here on the left prior to initiating MAT therapy. I just have this in a table format here. So I wanted to talk a little bit about buprenorphine individually. Induction should be initiated when the patient has objective signs of withdrawal. Typically, the patient needs to abstain from opioids for at least 6 to 12 hours. If patient's taking fentanyl, it should be more than 12 hours. I've looked at the SAMHSA Quick Start Guide, which I've also linked to the toolkit, and they recommend greater than 12 hours. And when the patient has objective signs of moderate withdrawal, so the COW scale needs to be greater than 12, and that will help to decrease any risks of precipitated withdrawal. Induction can be performed in an observed clinical setting at home, or and that should be determined by your clinical judgment. Typically, the dosing started with 2 to 4 milligrams and titrated up to patient's comfort level. And according to the ASAM guideline, a typical effective daily dose is 16 milligrams, although higher doses may be required. And there's limited data on efficacy over 24 milligrams, as it may increase risk of diversion. And again, there's no recommended length of treatments and should be individualized. And I really love this visual for induction steps because It's so extremely easy to follow. I've linked this as to the toolkit as well as the SAMHSA 2021 practical tools for prescribing and promoting buprenorphine in primary care settings, as well as the quick start guide I was referring to as well. It has some great flow sheets on there too. I know that there are other types of inductions that are now emerging. And in my resources, I have lists a systematic review on these different types of microinductions, which are shown to be beneficial and reducing precipitated withdrawal and, alleviating some of the barriers there were to having to be in withdrawal to obtain to initiate buprenorphine. So for patients have to undergo have to be in withdrawal, and that could be uncomfortable at times. So the other methods for microdosing inductions include, using, to my understanding, using an agonist as well, and kind of in smaller dosing, and it helps to better transition the patient to buprenorphine. So that's also that's in the references if you have the PDF version of the presentation. And I have just here the different formulations for buprenorphine. There are many different formulations. This table is adapted from the National Practice Guideline. It's in there. So if you, the ASAM 2020 National Practice Guidelines, so if you want to check that out, you'll see this there as well. And then here I've included a resource to the toolkit. It's a PCSS resource. It's patient information. It's under the patient education section for maintenance and treatment information. And then I have included the HHS practice guidelines for the administration of buprenorphine for treating opioid use disorder as well. And that's like they're more so like a policy statement. Now I'm going to talk a little bit about naltrexone. Naltrexone, the brand name is also known as Vivitrol, the injectable form is. And Vivitrol is, as I discussed, is preferred over the oral formulation because of the low rates of acceptance and high rates of non-adherence. It contributes to a lack of efficacy. So in most cases, the injectable extended release injectable naltrexone is preferred. And the injection is 380 milligram IM injection. It's given every 28 days. A naloxone test dose is performed prior, and if withdrawal symptoms are present during this test dose, then it's recommended to wait at least 24 hours and repeat the test dose. And this is to avoid any precipitated withdrawal. And then in order to receive this injection, patients have to abstain from opioids for at least 7 to 14 days. And again, there's no recommended length of treatment for Vivitrol. And if treatment is discontinued, the important thing here is to warn the patient of increased risks of overdose because now they'll be opioid naive. So that's very important to go over with your patient. Should they decide not to comply with the next dose of Vivitrol, they will be at greater risk for overdose if they return to using at the same dosing they were before. I have some perioperative considerations here. This is mostly from the ASAM 2020 guideline, but it's important to note it's not, they say it's not necessary to discontinue buprenorphine, and full agonists can be given IV. If you do discontinue, if the treatment team decides that's best, it can occur closer to the day of surgery, either the day before, the day of, and their higher potency intravenous full agonists can be used perioperatively for analgesia. And then for naltrexone, the injectable naltrexone should be discontinued 30 days prior to planned surgery, but the blockade can be overcome with high dose opioids as long as they're in an observed setting. And for PO naltrexone, it should be discontinued 72 hours prior. Now I have another test your knowledge. True or false, a comprehensive assessment should be performed prior to initiating MAT, and treatment cannot be initiated until this essential step is performed. So the answer is false. Although comprehensive assessment is essential, it shouldn't delay initiating MAT treatment. Okay. According to ASAM, the typical effective daily dose of buprenorphine is, and I have a few different options here. So they've identified 16 milligrams as the typical effective daily dose. But I know that it can be different for every patient. So this slide, as some of you already know, that data waiver, ex-waiter waiver, and the notice of intent, they've been completely removed on April 21st, 2020. The HHS updated their policy advocating for this removal. And then in December 29th, 2022, as a part of the omnibus bill that removes the federal requirement for practitioners to submit a notice of intent in order to prescribe buprenorphine. And this is now federal law, and SAM says no longer accepting waiver applications, but practitioners and providers need to be aware of their individual state's legislation when prescribing buprenorphine. So this slide reviews some information on harm reduction. According to SAMHSA, harm reduction involves direct patient engagement to prevent overdose and prevent disease transmission and improve overall quality and well-being. And I have this from the Harm Reduction Coalition. It incorporates a range of strategies that include safer use, manage use abstinence, and meet people where they're at. And some of the strategies that can be used in harm reduction include co-prescribing naloxone, strange exchange programs, fentanyl test strips, and education on the safer using practices, such as never using alone. And I've linked to the toolkit, the North America Syringe Exchange Network Needle, North America Syringe Exchange Network Needle Exchange Locator. And then a CDC resource, which is how to use fentanyl test strips, but make sure you check your state legislation, as these are not legal in every state. And then I just want to go over the impact of word choice. The inappropriate word choice can be embarrassing, hurtful, and have oppressive connotations. It can potentially contribute to stigma. So we want to make sure that we're using empathetic and appropriate language when treating our patients. And I have a table here. It's from NIDA. And there's a more expanded version of this table on their website, but it has some terms of, instead of using this, use this. So I have that there, and hopefully we can help to eliminate stigma associated with opioid use disorders through the impact of word choice. I thought this kit was helpful. It's from the ATTC, which is the Addiction Technology Transfer Center Network. It's the perinatal provider toolkit, and it provides information and support for healthy pregnancy. And I've linked that to our toolkit. And then these are the 6 building blocks from ARC, and focuses on key areas to guide treatment of patients who are using long-term opioid therapy. There are actually 2 versions of this, of the building blocks. There's like a streamlined version for institutions that already have developed initiatives in this area. And then there's more of a step-by-step version. And I think that takes 12 to 15 or 9 to 15 months. And that includes step-by-step instructions and resources. And this toolkit has helped to improve the health of patients, as well as the experience of providers and staff. The IPN, or the Intervention Project for Nurses, They receive referrals from nurses themselves through self-reporting, employers, treatment providers, and directly from the Department of Health or Board of Nursing. And this organization works with a nurse who has substance misuse in a supportive way to offer services and ensure the safety of patients. So the nurse works with the IPN to engage in an individualized plan. Often this can require temporary leave, sometimes it doesn't. And then when they return to work, there's at times worksite monitors to ensure the safety, but sometimes monitoring isn't required. But it's important to note that it's under the mandatory reporting law. All licensed nurses must report any suspected impairment to the Department of Health or IPN. And for our colleagues who are not nurses, similar resources are provided through the Professional Resource Network. And I've linked the referral to the toolkit. Now I'm just going. I'm sorry.
So given time, I think it would be really helpful if we could pull up the toolkit itself and just show how that's organized, because all of
you
have access to it? Okay. Because all of the guidelines and handy tools like the templates, calculators, screening tools, and all of that are available via link here to help everybody be able to better access this information. So we have a whole variety of excellent guidelines created by our organizations, but they're so all over the place on the internet. So this is a tool to help you locate what is quality right now at this time and what's most up to date, and the go-to places to get forms and templates and things like that.
Can you see the guidelines? I'm sharing it right now, kind of going up and down.
Sure. So this is what we put in the chat there. So there's a link to this. And yeah, if you could start on the first page.
Sure.
To show, yeah. So this is what's in the chat. And the guidelines that we created go by first what's available for clinical guidelines. So if you're prescribing or managing people who are on opioid therapies, those are the guidelines for specific situations related to that. And then if you're looking for resources for your patients on patient education on specific topics related to opioids or special populations, then you can access tips and guidelines and educational materials like infographics and things like that for your patients that way. And then diagnostic tools, screeners and things like that, you want to link directly to the screener so you can download it for your patients. It's available there. Other toolkits by our great organizations who have been working on this for a long time are available. Directories, so if you want to reach out to specific organizations or about specific guidelines or find things like our drug take back days, things like that. All of those are available there. And then additional things that were really helpful in putting together this overview of best practice guidelines. So make sure you download that. I know there's a whole lot out there on the internet, and it's really hard to wade through all of it and find out really what that quality stuff is, or where that specific form is, or if there is a form available for addressing this, or an informational sheet or a brochure on addressing this. This will help pull it together for you a little bit better and get it really out and used in your practice.
That is helpful. And then I'm going to go over some Florida specific information. And then we're going to drop the post survey into the chat, and please complete the post survey. We definitely appreciate the responses. So in reviewing some of the Florida specific information here, there are considerations for prescribing opioids in Florida, and I have listed some of these here. They are taken from the Florida statutes. So for chronic non-malignant pain, it's pain. They have a definition of it here. And you want to make sure that you're documenting all of these components listed appropriately in the record. And then they require a use of a written controlled substance agreement outlining the patient's responsibilities. And so they've listed these bullet points here. And the patient, again, must be evaluated every 3 months at minimum. That's consistent with that CDC guideline. And then for the management of pain with any patients with a comorbid mental health disorder, it requires extra care and monitoring and requires a consultation or referral to addiction medicine specialist or a psychiatrist. And for chronic pain, you have to specify on the prescription non-acute pain. For acute pain, for Schedule 2 medications, a 3-day supply can be prescribed unless an exception is made in which a 7-day supply can be prescribed. A 7-day supply can only be prescribed if the prescriber believes that more than a 3-day supply is necessary, and they have to indicate acute pain exception on the prescription. So there are a lot of rules here to become familiar with when you are prescribing an opioid. And you have to adequately document the acute medical condition and lack of alternative treatment options in the record. And it's important to note that if the patient has an injury severity score of 9 or greater, the practitioner should also prescribe, and the practitioner prescribes the Schedule 2 medication, then an opioid antagonist also has to be prescribed. And I've listed here the Florida DOH pamphlets as part of the non-opioid alternatives laws. This is a pamphlet located on the Department of Health website. And the provider has to review this pamphlet with the patient when prescribing an opioid and discuss the advantages and disadvantages on non-opioid alternatives and assess individual risk. And documentation of these considerations has to be made in the record. And the healthcare provider has to provide a copy of that handout as well, that pamphlet. And then I have linked here the different legislation that I've used in that section. It's mostly from the chapter 556.44 controlled substance prescribing, and I've hyperlinked to them so you can click on them if you have the PDF version. And then there's specific prescribing information here for advanced practice registered nurses as well as physician assistants. We do have a limitation in prescribing, which is just for Schedule 2 substances. It's limited to a 7-day supply. And then this chapter 893.03 displays the formulary and schedules of medications. And then this last chapter 456.031, it's the requirement for instructions on controlled substance prescribing. So that's the requirement of the biennial education. And this is, I thought this is interesting, found this at the Coordinated Opioid Recovery Program. So this is a program that links patients who require emergency services for opioid overdose with needed supportive services for hospital discharge. And it starts within the hospital. So the MAT started in the ER and then offered throughout the hospital stay. So this was developed in Palm Beach County in 2020, and now it's expanding throughout the state of Florida. Okay, and that concludes my presentation. Again, we're going to drop the link to the post survey in the chat if you can complete that. It's greatly appreciated. I have listed my email there for anyone who may have questions regarding the presentation. And I appreciate the time that you took to view my presentation. And I want to thank INSA and Dr. Domenico for having me.
Thank you very much for doing it. And I'm just getting that link again for the post survey here, and it would be very helpful. Oh, I think it's coming up here. Thank you all. I've been sort of going through trying to make sure I addressed everything for questions as we went. So I'll reach out to Sean to see about getting that link for the post survey in there. Should be coming up in a second. So as that's going, yeah, I just wanted to go back and thank everybody for attending and really encourage you to check out what is available regarding guidelines and tools out on the internet from those high quality sources like from our national organizations, because they are available and they aren't used enough. So they're there, and make sure they're incorporated into your practice so that we can really help our patients to the best of our abilities. Let's see. Still waiting on that link to come up.
Let me see if I can pull it into there.
Do you have that link, Allison, or is
Mm-hmm. Here, I have it here. Let me see. Okay. Let me just log into the chats. Okay, so I've dropped that into the chat. We definitely appreciate your feedback.
So we'll leave that up for another minute or so everybody can access that. If you have any questions, you can ask them now as well, or you can put them in the chat, whatever you're most comfortable with. There's a little conversation going on over there if you want to review the chat as well and see what questions were answered and asked over there. Okay. Well, I guess if nobody has any questions to ask, and doesn't seem like there's anything else appearing up in the chat there. So that'll conclude the presentation. We did put the notes in there. So if you wanted to go over the PowerPoint notes, make sure you do that, and make sure you use this time to download that toolkit as well, because that'll be a great resource as you're working with your patients. Thank you all for attending, and have a great rest of your day. Okay, I think everybody's gotten a chance to access those things. So if you'd like, we could just sign off and got that.
Okay.
Okay, so I'm going to sign out now, and you can sign it now as well. Thank you all if you're still on the line.